It's a pleasure to be here, even if it is virtual. My name is Mike Iadarola, and I thank the organizing committee for selecting this symposium to be presented at the USASP. I'm from the Department of Perioperative Medicine, also known as Anesthesiology, in the Clinical Center at NIH. And today I'm going to talk about elements of what I call the clinical pain neuron hypothesis. And there are two fundamental questions that we will examine. The first is, are there specific sets of neurons that uniquely contribute to clinical pain? And by that, I mean tissue damage pain. And I'm going to focus mainly on the dorsal root ganglion. And the other question is, can we leverage this knowledge for analgesic drug development? And I'll show you some data on one of the drugs that we've developed that's emerged. Now, in terms of the state of the pain field, I think that the number one overriding need is to develop new analgesic agents. And this is driven by the inadequacy of current analgesics, especially the opioids with all of their side effects, and the opioid crisis itself, which is being addressed by the NIH HEAL initiative. And one thing that we've done to address this clinical need is to develop resiniferotoxin, or RTX, as a new analgesic agent. So what is that? What's resiniferotoxin? RTX is a polycyclic diterpene, as shown over here, and it is a TRPV1 agonist. TRPV1 is a homodimer, and you can see that it is a key ion channel in nociceptive neurons. RTX treatment causes a highly selective chemoaxotomy, and we'll go into this in great detail. But our clinical trials of RTX demonstrate strong analgesia in patients with intractable pain from advanced cancer. And from this, we hypothesize that TRPV1 neurons are key transducers of both painful heat, as is well known, and clinical tissue damage. RTX has a highly selective action on human DRG neurons expressing TRPV1. Only a subpopulation in DRG express TRPV1. But given the variety of neurons that you see here in this in situ hybridization of human thoracic ganglion, you can see many different cells. Given the variety of cells, ones that make TRPV1, ones that make the ATP receptor, P2RX3, the opioid receptor. The big green cells are proprioceptors, and they make this molecule called SPP1 or osteopontin. And it's also found in satellite cells. So there's very distinctive populations, but how do we get at selectively the one that we want? And to do this, we developed a method called calcium overload, or this is the mechanism that we discovered. And that uses RTX to bind to the receptor. This is a homotetramer. You can see the lipid bilayer surrounding the molecule. And there are 4 molecules of RTX that bind to the homotetramer. And binding opens the ion channel and lets in a toxic amount of calcium, such a high amount of calcium that the cell cannot compensate for that. And it causes many problems intracellularly, as I'll show you. And there are 3 attributes of RTX that are kind of unique that allow us to that we exploit for therapeutic purposes and to produce the selectivity. The first is it's highly selective for TRPV1. If there's no TRPV1 in the cell, there's no RTX effect. And using NovaScreen, we examined about 300 molecules that might be binding using radioreceptor binding, and RTX did not bind to any of them to any appreciable extent. TRPV1 is selectively expressed in a subpopulation of DRG nociceptors. Other sensations, as I'll show you, remain intact since the corresponding neurons do not make TRPV1. And RTX produces a prolonged channel open time. Compared to capsaicin, it is extremely prolonged, and therefore it is better at letting in a toxic amount of calcium. So let's just look at some of the data. TRPV1 is selectively expressed. You can see TRPV1 immunohistochemistry in the rat trigeminal ganglion, or DRG, and there are a subpopulation of cells that make this. Not every cell makes TRPV1. You can see these large proprioceptors in the smaller panel right next to a variety of cells that make a variety of TRPV1 positive cells that are making different levels of TRPV1. And we assign certain functions to these, although we have not proved it in the human, that the small ones are, we're in the process of doing this, that the small ones, really dark ones, are the thermonociceptors, and the other ones mediate responses to tissue inflammation and tissue damage. The same pattern is seen in the human trigeminal ganglion. We have a subpopulation that makes TRPV1. There's high expressors and low expressors and no expressors. So the selectivity that we see in animals is also mirrored by the selectivity of expression in humans. And let's look at the mechanism of toxicity that RTX produces. It produces a prolonged channel open time. And in comparison to capsaicin, on the y-axis, RTX produces a much greater increase in calcium. The increase is much more prolonged. Here we're looking at the small pulse of RTX into the population of cells that make TRPV1. Capsaicin is washed in, it's washed out, the calcium goes up, the calcium goes down, RTX is washed in, calcium goes up much higher. Note that the y-axis is twice what in panel B as it is in panel A, much higher. And even though you wash the RTX out, the channel remains open, indicating that RTX binds pseudo-irreversibly to the TRPV1 homotetramer. Also, I might point out that the dose is about 1/500th that of capsaicin. So not only is it more potent and more effective and produces a prolonged action, but it's much more potent than capsaicin. And that confers some of the important aspects of its therapeutic action. And this rapid prolonged calcium elevation compromises the TRPV1 expressing cells. And one of the questions we asked was, what about the neurons next to the TRPV1 neurons as they're as they're undergoing a lot of changes due to the calcium influx? What happens to the neurons next to them? Is there a bystander effect? And we look at this in a couple of cells here in these four panels. There are two daughter cells. They're dividing. They pick up a plasmid that makes this TRPV1 EGFP fusion protein, so that wherever TRPV1 is, you see green color, and it's found in the plasma membrane and ER lattice. And then we also use mitotracker red to label the mitochondria of all the cells. So what you see here are the two daughter cells, and there's green and red in them, and the surrounding cells only have the red mitotracker. They did not pick up the plasmid. When you expose them to RTX, within 30 seconds, you can start to see modification of the ER lattice. And in 5 minutes, it's fragmented into small globules. And by 15 minutes, the nucleus starts to bleb out, as you can see there, and the plasma membrane starts to dissolve. And within about 30 minutes, the cell dies. So that was really, really interesting. But what's also interesting is that there's no bystander effect. Cells without TRPV1, the red only, are unaffected. Now, this idea, or this observation, comes right off the stage of a microscope and gave us the idea that we could maybe kill TRPV1 expressing cells. So how do we use this therapeutically? And here's an example, a diagram of the primary afferent route from the skin through the ganglion into the spinal cord, dorsal spinal cord. And using local RTX administration, you don't take this by mouth, you give it locally where the pain problem is, it produces a chemoaxotomy of the TRPV1 containing nerve terminals or axons. So we try not to go after the cell bodies in the ganglion, that will kill them, but if you apply RTX in several places, you can stop pain before it enters the CNS. Now this is really important. You want to block pain before it enters the spinal cord, and then you have this situation where the central nervous system does not experience pain, even though the tissue damage might still be present in the periphery. And you can give RTX in any one of several places: into the skin, perineurally, intraganglionically, or periganglionically. That works very well. Or into the CSF surrounding the spinal cord through lumbar puncture. And we have done an enormous amount of preclinical work. I call this the preclinical menagerie. They're in rat, dog, goat, horse, rabbit, and monkey. Some of the examples are shown here where we're giving it intrathecally into a goat with osteoarthritis, and then right into the nerve in a horse with lameness due to an injury in the hoof. And in the rat, we've studied many models. In the dog, we've studied osteoarthritis. It works very, very well. This is after an intra-articular injection into the knee or elbow joint of an arthritic dog. These would be people's pets. We inject them and the animal goes home and it actually runs around quite well. The same thing for osteosarcoma. Animals are recruited in what we call the companion canine model, and they're generally candidates for euthanasia, but they get treated and then the pain is cured or reduced and they go back home. So the same thing happens in all these, and we're working up protocols for trigeminal neuralgia, and that has necessitated us to inject RTX into the trigeminal ganglion in rabbits, monkeys, and rats. So we're working on a toxicology study for phase 1. So from here, though, we proceeded to an IND campaign and a human clinical trial to treat pain in cancer patients. And this shows you just the setup. So we have a human clinical trial. The eligibility is pain in the lower half of the body. We give an intrathecal injection into the cauda equina or lumbar puncture. And post-RTX injection, the pain is managed with IV opioids to counteract any residual pain from RTX. So if you inject it, obviously it's going to activate the receptors, and that produces quite a bit of pain. And needless to say, the patients in this study are all anesthetized. And when we give RTX, we get a zone of effect in the cauda equina. The site of the catheter is right about here, and there's like a cloud of RTX that basically produces this chemoexotomy of every axon that makes TRPV1, starting from about L2 all the way down to S4, S5. And I think it's kind of interesting to say, well, what does this look like? So I got some cauda equina tissue from the morgue in the laboratory of pathology here at NIH, and this just shows this mass of fibers that actually is the cauda equina. Nothing like that diagram over here, and it's filled with fibers. And somehow or another, and I spread them out over there, somehow or another, RTX finds its way and to the TRPV1 ion channel and opens it up, but doesn't have any bystander effects. There's no effect on the other fibers that don't make TRPV1. So what kind of pain problems can we treat here? There's a real need for palliative care. And this is I just showed this example of one of our patients. It's a 45-year-old female. She had metastatic cervical cancer. There was invasion of the pelvic walls. The ureters and vena cava were compressed. She couldn't pass urine. She had these nephrostomy tubes bilaterally in the kidneys to drain urine. There was a huge metastasis in the lumbar plexus, which was causing her a lot of pain. And even more so was this large erosion and metastasis in the L2 vertebral body. And this patient could not stand up or could not lie down flat. But after treatment, she was able to walk around quite well and was able to lie flat. So and could engage with her family and everything. And it was quite a remarkable recovery. In fact, it was almost too good because she was playing with her grandson and pulled out the nephrostomy tubes, and they had to be reinserted. So we've now done more patients, and they generally show a good pain reduction, and it's a prolonged pain reduction, and it's just from a single injection. So here we're starting at a relatively high level of pain, somewhere between a 10 and a 7, and it's reduced by about 50% in almost all the patients, and that stays down all the way out for 6 months. Now, if you look at the N in each bar, it gets smaller and smaller, and that's due to attrition because of progression of the primary disease, not necessarily withdrawal of the patient. So we have this quite effective treatment in very severe pain patients, and what we see is we've now treated 19 patients, all the patients, so reduction in pain, reductions in opioid use, and a sustained effect after one injection. So this is very selective. The fibers are cut. All other fibers remain intact. That includes touch, pressure, pinch, proprioception, not hot, hot is gone, and cold. So that's one of the things that we try and maintain is keep the drug at the lower half of the body so that they can maintain thermal sensation in the fingers and the mouth, because the patient does go home, they do experience a thermal environment, and they have to prevent burns. So that's why we treat people with problems in the lower half of the body. And this just reiterates what difficult cases that we address. But one thing I didn't mention in the previous slide was that this patient rated pain as a 9 or a 10 out of a 10 scale. She was getting 50 milligrams of Dilaudid per day plus a fentanyl patch. And that comes out to about 600 oral morphine equivalents, which is an enormous amount of opioid. And it's basically a lethal dose for several people. And she's sustaining this all day long, every day. Interestingly enough, very rapidly, she voluntarily reduced her opioid intake and became much more alert and much more active. And these are the two sites that cause most of the problems. So what other pain indications might we treat with interventional RTX? Remember, it must be injected next to the pain generator. And we've looked at indications like osteoarthritis, trigeminal neuralgia, phantom limb pain, post-herpetic neuralgia, neuromas after nerve injury, post-surgical pain, and low back pain. And the routes are all varied, but again, it's placed next to the pain generator. And for the knee osteoarthritis, it's intra-articular. For trigeminal neuralgia, we're either going into the nerve or into the ganglion. Same for phantom limb pain. And for neuromas, it's going to be perineural, proximal to the neuroma. So TRPV1 neurons, I think, based on the cancer pain and all of these other indications, I'm not going to show you the data from them, but they occupy a key niche in nociception. And it's very versatile. You can match the pain treatment with the pain problem. And all of these scissor sites that you see here are places where TRPV1 intervention and pain control is appropriate. I always say that if you can point to the pain problem, if the patient can point to the pain problem, then they're good candidates for RTX. But importantly, this is where the clinical pain neuron hypothesis comes in. What fundamental knowledge do these RTX TRPV1 trials reveal about pain and nociception control? So the first thing is what I call the primacy of the primary afferent input. If there's no peripheral input coming from the periphery and going into the spinal cord or reaching the brain, then there's no pain. That's sometimes hard to accept, but that's what the data says. The TRPV1 neurons, I think, the data also suggests, indicate that they are the most important DRG neurons carrying clinically relevant pain information. So no TRPV1 neuron equals no pain input equals no pain to the brain. Using lidocaine in various conditions, it's been shown that, and in these cancer patients, reversal of chronic pain happens in a matter of minutes, while central sensitization is still present in the brain or in the spinal cord after, let's say, cessation of the peripheral input. Without the peripheral input, the CNS alterations sort of become immaterial. They might be there, but since they're not being driven, they don't really produce pain on their own. And in fact, that's what I would like to say here, is that there's no autonomous pain avatar roaming throughout the brain. No pain input from the periphery, no pain in the brain. So these are really important concepts. And it focuses our attention on the TRPV1 neuron. And these neurons come in a couple of varieties. And this is just sort of one kind of breakdown where you have the TRPV1 neurons that make the opioid receptor and a population that do not make the opioid receptor. And these can be broken down into various subcategories as well. The peptidergic C nociceptors, silent C nociceptors, non-peptidergic C nociceptors, and some of these subserve sensitization of the periphery. Others are involved in neuropathic pain. Neuropathic pain is most likely this population right here, the OPRM1 negative, because intrathecal opioids do not work very well to treat neuropathic pain. And even though these might be the neurons that are transmitting it, you can't really control them very well with an opiate. Whereas tissue damage pain is quite amenable to being treated with an opiate. And we go through that analysis in this Cell Reports Medicine paper from last year. So these guys are the clinical pain neurons. And if I'd like to conclude, like Euphorbia resonifera, similar to opium poppy, it's been known to produce an irritant for more than 2,000 years. But it's only now that we're understanding how to use it, whereas people have been using opioids for like 5,000 years. I think that we are entering now a new route for pain control and a new era for pain research by focusing on these neurons and what other molecules that they make, and how to leverage that knowledge of other molecules and ways of manipulating these neurons. So if we block their input, we get a selective reduction in pain. So I thank you for your attention. The Department of Perioperative Medicine, the NIH, even though it's undergoing a lot of upheavals, here we are. We managed to at least come here virtually. Thank you.